Welcome to the deep dive. Today, we're undertaking a really crucial mission, decoding the layered complexity of breast cancer risk factors. For you, the learner, this isn't about generalized health advice. This is about moving past awareness into, well, real clinical understanding.
Yeah, navigating the specifics.
Exactly. The highly specific, complex variables and the exact quantifiable relative risks. The things that truly define who falls into a high-risk category and, importantly, why.
Right.
We're basically translating the foundational principles that guide surgical oncology and preventative medicine into actionable knowledge.
That's the critical difference, isn't it? Our source material gives us this rigorous framework, treating risk as a spectrum.
The spectrum. Okay.
And we're going to explore that entire landscape, starting with the broad population risks, lifestyle, hormonal exposure, then moving through those microscopic indicators from pathology report.
Right, the histology.
And finally culminating in the high-stakes, high-penetrance genetic mutations that, well, they largely define individual and familial destiny.
Okay, let's unpack this then. Our mission is to categorize these factors and critically define the mechanism behind them. We really need to know the why.
The why is key.
And we need the numbers, the exact relative risks cited in the source, to fully appreciate the clinical gravity of these markers.
Absolutely.
Understanding the mechanism, well, that allows us to understand the management, right?
Precisely. If we know that increased risk is tied to cumulative exposure, then will prevention strategies immediately become focused on reducing that cumulative load?
Whether that's through behavioral change or medical intervention.
Exactly.
Let's begin where the non-genetic discussion almost always starts. Estrogen exposure. It feels like the fundamental engine driving most of these risk factors is just the total amount of estrogen a woman's breast tissue sees over her lifetime.
That is absolutely the core hypothesis. You can kind of think of it in terms of mileage,
Mileage, okay.
The fundamental principle is that increased lifetime exposure to estrogen is associated with increased risk.
And the flip side.
And conversely, strategies that reduce that cumulative exposure are protective. The estrogen is thought to stimulate epithelial cell division,
Right.
which increases the opportunity for random malignant errors to occur and, well, accumulate over time.
So if we look at a woman's reproductive life, factors that extend the duration of her menstrual cycling,
Yes.
and therefore extend the period of high estrogen and progesterone stimulation, those are automatically risk enhancers.
That's right. And these are powerful, often non-modifiable factors that healthcare professionals use in those initial risk assessments.
Okay.
We see three primary markers increasing the total number of cycles. First, early menarche, starting periods early.
Right.
Second, late menopause, extending the fertile period late into life.
Makes sense.
And third, nulliparity, never having had a full-term pregnancy.
And why is nulliparity a risk?
By not having a pregnancy, you avoid a period of sustained hormone suppression. And crucially, you also miss out on a key protective event we'll get into.
Okay. So if increasing the number of cycles is a quantifiable risk, what about factors that actively decrease that exposure? The protective ones.
Yeah, the sources highlight two primary modifiable factors that decrease risk by reducing the total menstrual burden over time.
Look white.
Moderate levels of exercise are protective, partly by influencing body fat composition and partly, potentially, by altering hormone metabolism.
Okay, exercise. And the second?
The second is a longer lactation period. Extended breastfeeding suppresses ovulation and menstruation.
So it provides a natural break.
Exactly. An effective, natural, multi-month break from that cyclical hormonal stimulation.
I want to spend a moment on pregnancy timing, because that's where the mechanism gets really interesting, isn't it?
It really does.
It's not just the 9-month break from cycling that's protective. It's something more permanent happening to the breast tissue itself.
Exactly. The source highlights that the most significant protective effect comes from what's termed the terminal differentiation of the breast epithelium.
Terminal differentiation. That sounds very definitive. Can you break that down a bit for the listener? We're talking about the cells maturing.
That's a good way to put it.
And essentially losing their ability to respond to those proliferative signals. Is that right?
That's the perfect analogy, really. During the final stages of a full-term pregnancy and then lactation, the breast epithelial cells, which are normally somewhat immature, undifferentiated, and more susceptible to malignant changes. They mature into their final secretory state. Once they achieve this terminal differentiation, they are biologically much less vulnerable to carcinogenic insults.
Like turning a vulnerable sapling into a strong, mature tree.
That's a great image, yes.
And this mechanism explains why the timing is so critical. The older a woman is at her first live birth, the higher her breast cancer risk.
Yeah.
Is that connection clear?
Precisely. If she's, say, 35 when she has her first full-term birth, she's already accumulated maybe 15 to 20 years of estrogen-driven cellular insults without that protective differentiation kicking in.
So the differentiation still happens, but later.
It still occurs, yes, but it happens on an older, potentially more damaged substrate of cells. In fact, there's a fascinating detail here. In the short term, a woman's risk of breast cancer slightly increases immediately following a full-term pregnancy.
Really? Why?
Well, before the protective effects of that terminal differentiation are fully realized, it just reinforces the complexity of this whole hormonal dance.
Wow, okay. That is definitely a deep dive nugget right there. Let's shift gears, though, to a situation where the hormonal landscape changes completely. The link between obesity and breast cancer, particularly postmenopausally.
Yes.
It feels a bit paradoxical because reproductive hormones are supposed to be tapering off then.
This is a vital distinction, and it demonstrates a secondary but still powerful mechanism for estrogen exposure. We call it peripheral aromatization.
Peripheral aromatization.
Okay. Before menopause, the ovaries are the main engine of estrogen production.
Right.
After menopause, the ovaries involute, estrogen production plummets, but the body is clever. It finds a secondary peripheral source.
And that source involves fat tissue.
Correct. What's really fascinating here is that the major source of estrogen in postmenopausal women, specifically the weaker but long-acting estrogen called estrone,
Okay.
is the conversion of the hormone androstenedione, and this conversion is carried out primarily by an enzyme aromatase, which is highly expressed in adipose tissue, fat tissue.
So the fat tissue essentially becomes this big, diffuse estrogen factory working outside the ovaries.
Exactly that. The more fat tissue a woman carries postmenopausally, the greater the number of these little aromatase factories she possesses.
Leading to more estrogen.
Leading to a greater long-term chronic increase in circulating estrogen levels. This directly links postmenopausal obesity to an increased risk of breast cancer.
So it's a risk factor that a woman essentially carries and, well, cultivates throughout her later life.
It is, and it makes weight management a clear, evidence-based preventative strategy in this context.
Okay, now we transition away from the natural hormonal cycling to risks that involve more extreme environmental exposures or long-term habits. And honestly, nothing in the source material is quite as chilling as the statistics around radiation exposure.
Yeah, this section really underscores that while hormones kind of set the stage, certain external factors can act as extreme risk accelerators. Radiation exposure is the most powerful example of a risk multiplier, and the effect is, well, catastrophic depending on the timing.
Let's start with the most extreme example cited. Young women who receives mantle radiation therapy for Hodgkin's lymphoma. The number is just staggering. Their breast cancer risk is cited as being 75 times greater than age-matched controls.
That number isn't just academic. It dictates medical practice for their entire lives. A 75-fold increase puts these individuals in a unique, extremely high-risk category.
And that's a direct consequence of the radiation-causing mutations.
Yes, inducing somatic mutations in that vulnerable breast tissue, making the cells inherently unstable.
And the second example, reinforcing this, the historical one, is the high incidence among survivors of the atomic bomb blasts in Japan during WWII.
Both scenarios really hammer home the power of the dose-response relationship and the nature of the damage direct high-energy insults causing mutation. But the clinical takeaway, as you hinted at, is the age factor.
The tunning. Critical vulnerability.
Yes. Radiation exposure during adolescence, that period of rapid and active breast development where the epithelial cells are proliferating and differentiating really quickly, that magnifies the deleterious effects significantly. Those rapidly dividing, vulnerable progenitor cells are just far more susceptible to mutation.
And if it hits a stem cell?
If the mutation occurs in a stem cell, the consequences are incredibly long-lasting. For these patients, standard screening is completely insufficient.
So what do they need?
They require intensive, typically annual screening that includes both mammography and breast MRI, starting years, sometimes decades, earlier than the general population.
Wow, that really contextualizes the magnitude of that 75x risk dramatically. Okay, now let's look at the modifiable lifestyle factors. specifically alcohol and diet, and how they connect back to that hormonal mechanism we discussed.
Right. With alcohol, the source indicates a very clear dose-response relationship.
Meaning?
The risk of breast cancer increases linearly as the amount of alcohol consumed increases. And importantly, this isn't just some arbitrary correlation. We actually know the mechanism ties directly back to estrogen.
So it's not simply the toxicity of the alcohol itself.
Right.
It's affecting hormone regulation.
Correct. Alcohol consumption is known to increase serum levels of estradiol, which is one of the most potent estrogens.
How does it do that?
It's thought that alcohol interferes with the liver's ability to properly metabolize and clear circulating estrogen from the blood.
So it's like recycling the estrogen.
Essentially, yes. Or prolonging the time the breast tissue is exposed to these proliferative signals.
So if we're thinking mechanistically, chronic alcohol consumption works on the liver to boost estradiol, similar to how postmenopausal obesity uses fat tissue to boost estrogen.
That's a great comparison.
Two different pathways, same result. Increased lifetime estrogen exposure.
Exactly. They are both contributors to that cumulative hormonal load. And similarly, long-term consumption of foods with a high fat content is cited as contributing to increased risk.
Okay, the high-fat diet link.
Now, dietary research is always evolving, complex stuff, but the source maintains the link by stating that high-fat intake also contributes to increased serum estrogen levels.
Any idea how?
Possibly by changing bile acid metabolism or maybe indirectly through weight gain. Either way, it reinforces the general principle. Lifestyle choices impacting chronic hormonal elevation are risk factors.
This moves us into the pathological realm. We're talking about findings discovered during, say, a biopsy or imaging that are not yet cancer, but signal a drastically elevated risk profile for the future.
Exactly.
This is critical for the listener, I think. When you have a lump, how do doctors differentiate between a truly innocent finding and a marker of future danger?
This is where we shift from those broad epidemiological risk factors to internal tissue-level indicators. The histology gives us a quantifiable spectrum of risk.
Okay, a spectrum. What's at the low end?
At the low-risk end, the baseline, we have the non-proliferative disorders. These account for the majority, maybe 70%, of benign breast conditions. Things like cysts, fibroadenomas, ductictasia.
And the key point.
Crucially, these carry no increased risk for future cancer development. They are statistically equivalent to the risk of the general population.
That must be a huge reassurance for many patients.
It absolutely is.
But when the pathology report mentions proliferation cells dividing more rapidly than normal, that's when the clock starts ticking faster, so to speak.
That's when the relative risk becomes quantifiable based on the degree of cellular change. Florid hyperplasia, for instance.
Okay, what's that?
That's an increase in the number of epithelial cells, but without any real structural abnormalities or atypical features. That already carries a 1.5 to 2-fold increased risk.
So a mild elevation.
Yeah, mild. Suggesting a slightly hyperactive cell line, maybe?
But the risk jumps dramatically once the cells begin to look atypical.
Yeah.
This is where the specific numbers become really critical, isn't it?
Absolutely. When we see atypical lobular hyperplasia, ALH, or atypical ductal hyperplasia, ADH, the risk profile escalates significantly. Both of these conditions confer a 4-fold increased risk of developing invasive breast cancer in the future.
4 times the risk. That's serious. What does that mean for the patient in practical terms?
A 4-fold risk means the patient is placed into an immediate, specialized surveillance program. These patients often require intensified screening, sometimes including annual MRIs in addition to mammograms.
Okay.
And they're often counseled on the option of chemoprevention, which we'll talk about later. But even this risk profile can escalate further based on location.
You're referring to ductal involvement by those ADH cells?
Yes. If the atypical ductal hyperplasia cells are found to be significantly involving the ductal structures, the source material cites an escalation of the risk up to 7-fold.
7-fold. Wow.
The difference between 4-fold and 7-fold might seem subtle pathologically, but it represents a critical threshold for intervention. It often cements the decision to pursue aggressive surveillance or pharmacological risk reduction.
Okay, this brings us to carcinoma in situ, which represents the highest histologic risk short of invasive cancer itself.
That's right.
We have ductal carcinoma in situ, DCIS, and lobular carcinoma in situ, LCIS, both conferring the same 10-fold increased risk apparently, but signaling danger in entirely different ways.
This distinction is absolutely crucial for clinical management. Yes, both DCIS and LCIS confer a 10-fold increased risk for subsequent invasive breast cancer. Huge risk.
Let's start with DCIS. The sources classify it as an anatomic precursor. What does that imply for managing it?
As an anatomic precursor, DCIS is generally understood to be, well, cancer cells confined within the ductal system.
Stage 0, essentially.
Kind of. And if left untreated, they would likely breach the basement membrane and become invasive ductal carcinoma. Because of this, the risk is predominantly local.
Localized to where it was found.
Exactly. If invasive cancer develops, it typically occurs in the same breast and often in the same quadrant where the DCIS was found, what we call ipsilateral risk.
So management is local too.
Management almost always involves local clearance, usually lumpectomy plus radiation, or potentially mastectomy if the area is extensive.
Okay. And LCIS, that's where the concept of risk shifts entirely from local to systemic.
Yes. LCIS is fundamentally different. It's viewed less as an inevitable precursor, like DCIS, and more as a marker of increased systemic risk.
A marker, what does that mean?
The small monomorphic cells that characterize LCIS are often just an incidental finding on biopsy, but they signal a profound systemic susceptibility to malignancy. Critically, subsequent invasive cancer can develop in either breast. It signifies a bilateral risk.
A tenfold risk profile, but bilateral. That completely changes the management strategy, doesn't it?
Absolutely. Because LCIS is a marker of bilateral risk, just locally removing the finding isn't enough to address the systemic problem.
So what do you do?
Management focuses heavily on surveillance, chemo prevention using drugs like tamoxifen, or frequently considering bilateral risk-reducing mastectomy because the danger exists in both breasts simultaneously.
Interesting.
The data also suggests a racial predilection here, noting that LCIS is found about 12 times more frequently in white women than in African-American women. That's an important epidemiological detail from our sources.
Okay, here's where it gets really interesting, I think. We're moving from accumulated risk and pathological findings to the defining role of inherited genetics.
Right.
The, 5% or so of breast cancers caused by these high penetrance mutations? This is the domain of BRCA.
ERCA1 and BRCA2 are definitely the titans of inherited breast cancer risk. They're tumor suppressor genes.
Meaning they normally stop cancer?
Yes. So the initiation of cancer requires the loss of both functioning alleles, following what's known as the two-hit hypothesis.
So a hit.
But because these mutations are inherited in an autosomal dominant fashion, the carrier is born with the first hit already sustained in every single cell of their body.
Wow. Okay.
Which makes the likelihood of the second somatic hit happening somewhere, sometime, astronomically high.
Let's quantify that high risk.
Yeah.
What's the lifetime expectancy cited for female mutation carriers?
The estimates are dramatic. Female mutation carriers have an estimated average lifetime risk of developing breast cancer somewhere between 60% and 70%.
60 to 70%.
And in certain families with particularly aggressive backgrounds, that risk can surge even higher, potentially reaching up to 85%.
85%.
Yeah.
And the risk profile isn't just confined to breast tissue, right? This is critical for management.
Indeed. These mutations significantly increase the risk of ovarian cancer as well.
How much?
BRCA1 carriers face a lifetime risk for ovarian cancer estimated up to 40%.
40%.
While BRCA2 carriers have a lower but still substantial risk, often close to 20%. This dual organ risk makes preventative surgery a potentially life-saving decision for many carriers.
Now, for the practitioner or the informed patient listening, it's vital to know that BRCA1 and BRCA2 aren't interchangeable, are they? They produce different cancer phenotypes.
Yes, the type of tumor that results from the mutation is distinct.
And why does that matter?
This is a vital distinction because the phenotype often drives the treatment plan. BRCA1-associated cancers are generally early onset, occurring at younger ages, and they're associated with a higher prevalence of bilateral cancer. Crucially, they are typically triple receptor negative, meaning they lack receptors for estrogen, ER, progesterone, PR, and the HER2 protein, or what we term the basal phenotype.
Why does being triple negative make treatment more challenging?
Well, triple-negative cancers lack the hormone targets that drugs like tamoxifen or aromatase inhibitors exploit.
Ah, I see.
This means they are often biologically more aggressive and less responsive to targeted therapy, typically requiring reliance on standard chemotherapy regimens. It's a key reason why prophylactic surgery is often strongly recommended for BRCA1 carriers.
Okay. In contrast, BRCA2 cancers present a different biological challenge.
Yes. BRCA2-associated cancers are more likely to be well-differentiated and, significantly, they tend to express hormone receptors. They're often ERPR positive.
So they can be targeted by hormone therapy.
Exactly. While the overall risk is still extremely high, the hormonal positivity means they are potentially good candidates for targeted endocrine therapies. That offers an additional layer of potential prevention and treatment success compared to many BRCA1-associated tumors.
We also need to address the risk profile for men carrying these mutations, particularly BRCA2. It's not just a women's issue.
Absolutely not. Male breast cancer, while rare in the general population, is a significant risk factor for carriers. Men with germline BRCA2 mutations have an estimated lifetime breast cancer risk of about 6%.
6% might sound modest, but compared to the average man.
It represents a staggering 100-fold increase over the risk faced by the general male population.
Wow.
Furthermore, BRCA2 is associated with an elevated risk of several other cancers, too. Colon, prostate, especially aggressive subtypes, pancreatic, gallbladder, bile duct, stomach cancers, and even melanoma.
Given the hereditary nature, certain populations have these well-documented founder mutations that simplify genetic testing, right?
That's right. The Ashkenazi Jewish population is the primary example cited in our sources. They have a dramatically higher prevalence of specific, recurrent founder mutations.
Which ones?
There are three main ones: 185 DELEG and 5382 SCA in BRCA1, and 674 DELES in BRCA2. These three mutations account for nearly all BRCA-related cancers in this group.
So testing is more targeted.
Highly effective. For instance, that 674 DELET mutation in BRCA2 is responsible for something like 60% of ovarian cancer and 30% of early-onset breast cancer in Ashkenazi women. Targeted genetic panels work very well here.
Finally, beyond the two big ones, BRCA1 and 2, research is rapidly characterizing other high-risk genes. What about PALB2? That one seems to come up more now.
PALB2 partner and localizer of BRCA2 is probably the most significant recent discovery in this high penetrance category.
What does it do?
It functions as a critical scaffold protein, basically helping BRCA2 do its job in DNA damage repair.
And the risk associated with it.
Recent analyses cited in the literature suggest that the breast cancer risk for female PALB2 mutation carriers is nearly as high as that of BRCA2 carriers.
Really? How high?
The absolute risk by age 70 ranges dramatically, from maybe 33% up to 58%, depending heavily on the family history present.
So PALB2 needs to be treated with the same clinical seriousness as the classic BRCA mutations now.
Absolutely. It demands the same intensity of surveillance and risk management strategies, and we shouldn't forget other syndromes either.
Like Liefram-Meni.
Exactly. Liefram-Meni syndrome, caused by TP53 mutations, confers an exceptionally high risk of multiple cancers, including breast cancer, and Cowden disease, caused by PTN mutations, also confers increased risk alongside other specific tumor types.
Okay, we've covered this huge complexity of risk factors: hormonal buildup, environmental hits, pathology findings, genetics. Now, the application. How do clinicians actually synthesize all these variables into a quantifiable prediction for an individual patient?
Well, we rely on algorithmic risk assessment tools. The most widely used tool in the U.S. still remains the Gale model. It's foundational, really, because it captures the most common non-hereditary factors pretty well.
What are the main inputs for the Gale model? What does it look at?
The Gale model calculates a patient's 5-year and lifetime risk based on 5 main categories: the woman's age at menarche,
Okay.
her history of benign breast disease, her age at first live birth, and her first-degree family history of breast cancer. It takes these inputs and compares the resulting risk score to the adjusted risk of the general population.
So it's effective for standard risk calculation.
For standard risk, yes. But you mentioned earlier, there's a critical, potentially dangerous flaw in the original Gale model, particularly when you suspect hereditary risk.
Right. What's the flaw?
Yes. The biggest limitation, and the source material really emphasizes this, is that the original Gale model does not effectively account for the risk associated with mutations in those high-penetrance genes like BRCA.
So it underestimates the risk for those individuals.
Dramatically. If a high genetic risk is suspected based on family history, a clinician absolutely must use a different or supplementary model. The Gale model alone just won't cut it.
Which brings us to the more comprehensive tool, the Tyrer-Cuzick model. How does this model integrate the complexity that Gale misses?
The Tyrer-Cuzick model, often called IDISTWRL, uses a more layered approach specifically designed to handle genetic risk.
How does it work?
It first uses detailed family history to calculate the probability that an individual carries a genetic mutation, BRCA1, BRCA2, and increasingly others like PALB2.
Okay, so it estimates the genetic likelihood first.
Exactly. Then it adjusts that calculated genetic probability based on a huge array of personal and hormonal factors, including age at menarche, parity, BMI, height, and crucially, a history of high-risk pathology like ADH or LCIS.
So it really tries to integrate the hereditary and the hormonal profiles into one score.
It does. It's much more comprehensive for potentially high-risk individuals.
Okay, so once that risk is quantified, let's say the patient is found to have a high lifetime risk.
Yeah.
What are the primary management strategies cited? Let's start with chemoprevention.
Right. Chemoprevention is using drugs to reduce the incidence of cancer in high-risk, otherwise healthy women. Tamoxifen, a selective estrogen receptor modulator, or SERM, was the first drug proven effective.
And how effective was it?
The landmark NSABP-B01 trial, that's the National Surgical Adjuvant of Breast and Bowel Project, demonstrated that tamoxifen use reduced the incidence of invasive breast cancer by 49% in the high-risk group receiving the drug compared to placebo.
A near 50% reduction is massive. But we need to connect this back to our earlier discussion about phenotypes, right? This reduction only applies to certain tumors.
Exactly right. Tamoxifen is essentially an anti-estrogen drug. It works by binding to estrogen receptors, blocking estrogen from stimulating those cells.
So it only works if the cancer cells have estrogen receptors.
Precisely. Its effectiveness is limited to ER-positive breast cancers. It offers no significant benefit against the ER-negative or triple-negative tumors.
Which, as we noted, are common in BRCA1 carriers.
Exactly. This is why risk stratification, knowing the potential tumor phenotype, is absolutely essential before starting chemoprevention.
Are there other options besides tamoxifen?
Yes, postmenopausal women often use different agents, like raloxifene and other SERM, or aromatase inhibitors like exemestane. These are also effective in reducing ER-positive risk, sometimes with potentially fewer side effects than tamoxifen.
Okay. Now, for the highest risk group, especially those with known BRCA mutations or maybe extensive LCIS, drugs might not feel like enough protection. Intervention often turns to more dramatic surgical strategies, doesn't it?
Risk-reducing surgery remains the most potent tool we have. Retrospective studies consistently show that prophylactic mastectomy, the removal of both breasts, can reduce the risk of breast cancer by more than 90% in high-risk women.
Over 90%.
It's a permanent decision, obviously, a huge one, but the efficacy is undeniable.
The source material also puts this into perspective regarding life expectancy for the most vulnerable carriers, doesn't it?
Yes, the benefit translates directly into years of life gained. For a BRCA carrier with, say, a moderately high estimated lifetime risk of 40%, prophylactic mastectomy was estimated to add nearly 3 years of life.
And for those at the highest end?
For women with the highest risk estimates, approaching that 85% mark, prophylactic mastectomy added more than 5 years of life expectancy. This data clearly demonstrates that for inherited risk, surgical intervention is highly impactful and often a necessary consideration.
And given the dual organ risk we discussed for BRCA carriers, breast and ovarian, we can't overlook risk-reducing salpingo-oophorectomy.
Absolutely. The removal of the ovaries and fallopian tubes.
Yeah.
This procedure is crucial for BRCA carriers, especially BRCA1. It dramatically reduces the risk of ovarian cancer, which is often detected late and has, frankly, poor outcomes.
But it also helps with breast cancer risk.
It does. It achieves a therapeutic goal for breast cancer by removing the major source of ovarian estrogen, inducing a surgical menopause. When performed premenopausally, this procedure also significantly reduces breast cancer risk.
When is that usually recommended?
For documented BRCA mutation carriers, this procedure is generally recommended between ages 35 and 40, ideally after childbearing is complete.
Wow. Okay, this deep dive has really spanned the entire spectrum of breast cancer risk, hasn't it?
It really has.
We began with that modifiable and non-modifiable hormonal load, saw the catastrophic magnification from an environmental radiation, deciphered the complex quantitative risks embedded in that proliferative pathology.
The fourfold, the sevenfold.
Right. And finally navigated the life-altering science of genetics with BRCA and now PALB2.
I think the key takeaway is synthesis. Breast cancer risk isn't defined by just one thing.
No.
It's the convergence and accumulation of many factors. It ranges from subtle modifiable things like BMI and alcohol consumption, all the way to highly specific non-modifiable indicators like an inherited mutation or a finding of atypical ductal hyperplasia.
And the sophistication of modern medicine lies in quantifying these factors.
Yeah.
The fourfold, the sevenfold, the 60% lifetime risk.
Exactly. To personalize prevention and guide aggressive screening appropriately.
And as we've seen repeatedly today, Whether we're talking about risk reduction via chemoprevention or risk-reducing surgery, the management strategies consistently target one primary goal.
Reducing the body's lifetime exposure to hormones.
Which leads us to our final thought for you, the listener, to consider.
We established early on that the protective effect of a full-term pregnancy is biological. It causes that terminal differentiation of breast tissue.
Right, essentially retiring those cells from their vulnerable proliferative state.
This suggests that perhaps the ultimate preventative measure might be finding a way to molecularly mimic this maturation process.
Triggering differentiation without pregnancy.
Potentially.
Uh,
If future research could isolate the specific growth factors or molecular signals responsible for achieving this terminal differentiation, could we develop a preventative drug that works not by blocking hormones, but by permanently maturing the breast tissue itself?
Moving us beyond the current limitations of just hormone-targeting chemoprevention.
Exactly. It's a question that connects the foundational reproductive biology we explored today directly to the most advanced frontiers of cancer research. Something to think about.